Totally clear, is it? Okay, what I'm going to talk about now, having set the scene for how we believe we get to the point where you can store urine and you can pass it as you choose, is what goes wrong and where does that come from? So the etiology of dysfunctions that we might see in children. So just the last slide comes back to haunt you, in case we'd had a break, just to see where we're up to in a reasonably normal cohort of children. By 4 years, they'll be in control of their bladder. Of course, this is not every child, and there are different presentations depending on who toilet trained the child and what the philosophy was, which country, etc., etc. Okay, but if we want to talk about not having control of your bladder, losing your urine, being wet, that's called incontinence, and we have to decide, is it happening all the time or is it only happening sometimes? It's a very basic classification. But you would be surprised that sometimes continuous incontinence is missed. Now, if you see continuous incontinence, that is, you stand a child there over a bluey on the floor and they're going drip, 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 then I put it to you that you shouldn't see that child anymore. They should go back off to the children's hospital and they should be investigated to find out where their ectopic structure is and why they are continuously leaking. It's not something that I think you can fix, so pass them on straight away. And very often the mother will be able to tell you, oh yeah, it stands in the shower or the bath, drip, drip, drip. And I have seen a few in my years of treating children, and they have all been when there's been an extra structure coming down from the kidneys and it's open, say, into the vagina or something like that. An ectopic structure. Not our business. Pass them on. More likely we're going to see intermittent incontinence. So times when the child is wet, times when they can store throughout the day, or being wet at night time. Now, there's a lot of terminology that the International Children's Continence Society have formulated so that we all talk the same language and we understand what we mean when we use certain words. And this is important because if we want to have good research in this area, we need to know that the children that we're talking about are the same. They're homogeneous, as we say. So let's just look at some of this terminology. We are using terminology put forward in the adult arena so that there is some aligning. So we could talk about lower urinary tract symptoms in children, and they are things like incontinence, urgency. Urgency is not a normal phenomenon. We all want to go to the toilet and are busting sometimes. That's not abnormal, but urgency where you actually have to apply some sort of pressure, cross your legs, squat down, hold with your hand, your eyes are blinking and you lose a few drops. That's abnormal. Hesitancy is when you get to the toilet but you can't actually start the flow of urine or it takes a while. Straining is when, as you're passing urine, you need to push with your abdominal muscles to try and get a bit more pressure. You can understand, can't you, what's going on with hesitancy and straining. There's something happening at the bladder neck or the sphincters that doesn't allow the urine to pass. There's some sort of obstruction, we would say, whether it's a functional obstruction or it's truly there as an organic issue. A weak stream, this could also be that there's some obstruction or that the detrusor cannot generate enough pressure. If the bladder has overfilled and does this routinely, because the child doesn't get the sensation that the bladder's full, then you can't get as much contractile pressure and the stream coming out is weak. And you would know this yourself if you have a big cup of tea in bed at night before you go to sleep. You don't go to the loo in the night time. You get up in the morning, you can't for quite some time because your bladder has been overfilled and it doesn't have the efficiency to empty at that stretch. You're with me here, aren't you? It's not just me. We've talked about posturing and holding. So they're the symptoms that we are discussing. And what's not in there is some sort of bladder pain or discomfort, but that may also be a point. We've talked about urge incontinence, when you leak at that eye-watering urge to go. And we call it the urge syndrome if that urge is accompanied by going to the toilet quite often and actually losing a bit of urine. So it's a three symptom syndrome, the urge syndrome. Now, usually, if we have the urge syndrome, we say the child has an overactive bladder. That means that instead of that nice round picture of the red detrusor with the yellow urine inside it, it's a bit like this. It's active rather than relaxed during the filling phase. And this occurs intermittently during the filling phase, not all the time. In children with a neurogenic problem, yes, it can occur all the time because the bladder cannot cope with increased pressure. But in children with urgency, there are waves of contraction. I often say it's like the childbirth contractions, and if you can find a strategy to get through that wave of contractions, it will go away. And then the bladder will fill up a little bit more, and then there'll be another one if you have this syndrome. Now, we also talk about how often children go to the toilet during the day. This is tricky because who knows? Kid doesn't know, parents don't know. You can only know if you've made an objective measure. So there's some sort of bladder diary that tells you exactly. And it has to be a bladder diary that's real time, not one that they made up just before they came in the door. And it has to be a bladder diary that tells you. I say to the children, it's like I want to stick a camera to your tummy, and I want it just to tell me what's going on in your real life. So there's no right and there's no wrong. And it's only in recent years that we've been worried about children who don't void frequently. We're all very worried about, if you void 7, 8 times or more during the day, that's important knowledge. But we also know now if you void 3, 2 or 1 times in a day, that's really important knowledge. And so don't forget the extremes. And then we come to my favourite children, who are the ones who can't empty in a coordinated fashion. They have what we call dysfunctional voiding. And somehow the sphincter mechanism stays partially shut during voiding. And we'll talk about that much later. It's a very, very interesting area, and I think we weren't very good at recognising this in children until recently. Now, how many of you work with adult bladder problems here? Okay, you suffer. You suffer a lot because in adults, we think that the overactive bladder comes first and then it causes all the other problems. But in children, we think the emptying disorder comes first and it causes the overactive bladder. So you have to have 2 sides of your brain working differently when you see a child versus when you see an adult. So that's the terminology. All of those symptoms can occur because there's an organic cause for it. There's some nerve damage, there's some structures that haven't developed properly. And I believe that this afternoon, when you have the paediatric urologist, he'll probably cover some of these things. So my presentations to you today are assuming that your child has been screened well by somebody who would be able to detect these organic causes. Not all of them you would be able to detect yourself. And this is the worry about working in private practice with children. You just can't know some of the underlying, you can't rule out some of the underlying possible causes if you're working by yourself. So it's always good to have had your child screened for these things. And I would say that you should set up some sort of collaboration with a person who can do good screening. Maybe it's a GP and maybe it's a paediatric team at your hospital. Because if you miss some of these things, then the condition will get worse. And when we're talking about worse in children with daytime wetting, there are some children that go on to end-stage renal failure. And you have to know how to manage the conditions that would potentiate that so that it doesn't occur. So put yourself in the clear and make sure your child has been well reviewed medically before you would start to work on them in isolation. So these are the things that I think we'll discuss later, and if it's not discussed, then we can make sure you get enough information about this. If we want to talk about how common it is to have poor bladder control during the day in childhood, it becomes difficult. We did the first study in Australia in 1988. where we could establish the prevalence of these symptoms at the time. And it wasn't that different from other developed countries around the world. And it really depends on the age and also the severity of the symptoms. You need to collect the information under those subcategories. And you can see here the figures. In 4-year-olds, maybe a third of them are going to have some bladder control issues. Coming up to adolescents, less than 2% of them will. So, of course, bladder control improves. What we have found in studies in Asia is that if you get to about 9 years old and you have these problems, they may not remit. There's something else that you haven't identified and haven't worked on. Now, remember I talked to you about the most common symptom in bladder dysfunction in children was the overactive bladder, the urge syndrome, where they have urgency, they're often wet at urge, and they go to the toilet a lot. That's the urge syndrome, the overactive bladder in childhood. And here's a study that was done not so long ago, looking at the prevalence of this particular disorder in Korea. And they used the definition that I've talked to you about, and they had quite a big incidence of overactive bladder. And some of them are wet, and some of them are dry. So most studies haven't made this classification. And of course it follows the line that we all know that as you get a bit older, you should see less children with the problem. This is not easy to read, is it? But it's just showing you the data by age. So this shows you that the prevalence is less as you get older. But the prevalence of overactive bladder is much higher than the prevalence of incontinence, because urgency symptoms don't always come with wetting. And this one here shows you the wetting and the not wetting, and you can see it's much more likely that you'll have overactive bladder without wet pants than you will have it with wet pants. This is interesting because when children come into the clinic for other issues, particularly nighttime issues, nocturnal enuresis, do you have any daytime wetting? No. But actually they do have daytime symptoms, but they're not wet. So it's a very important part of your assessment that you know which symptoms to ask about, because they won't volunteer this information because it doesn't seem odd to them because they're not wet. And here we've got some information from Japan, and these are older children. They use the same definition of the syndrome, and you can see here a similar prevalence to Korea of 17%, a little bit more in boys than girls. Then we come to two very interesting points. Oops, they were interesting. Two very interesting points here. Urinary tract infections and constipation. There's a trifecta that goes with daytime wetting, urinary tract infections, constipation, and reflux. Let me explain them to you. Let's start with reflux, which is not here. Reflux is when the urine goes back up the ureters towards the kidneys when it shouldn't. The urine, when you're in your filling phase, the urine should not be able to get into the ureters. But in some people it does. Now there are children who show this disorder in the early years of life, and we call that primary. And there are children that we now understand acquire this disorder because of high pressure in the bladder. And that's the really interesting group of children, because we have to find them, and we have to decrease the pressure inside the bladder to help them to reduce this reflux or backtracking that comes from a high pressure bladder. Of course, those children who have reflux are more likely to have urinary tract infections as well. And if the infection goes up to the upper tract, then you have pyelonephritis, etc., of upper tract damage and scarring of the kidneys. But I'm sure that will be discussed later today. But you can also have urinary tract infections that recur, recurrent urinary tract infections, without having reflux. You can understand how a urinary tract infection causes inflammation of the epithelium, and even after the bacteria has been treated and gone away, you still have inflammation of the epithelium. And if you get another one, you have inflammation on inflammation. And so it takes a long time for the epithelium of the bladder to return to normal. And you can see why that irritated epithelium would cause the overlying detrusor muscle to function abnormally, can't you? Can you understand that? Yes? And then we have constipation. This is the third one in our trifecta. Now, the jury's out on this. We understand that the bladder and the bowel are innervated largely from the same nerves, and they develop at the same embryonic stage. So there's a lot of commonality between the two systems. So it may be that, the same neural drive. It may be the mechanics of a big stool putting some mechanical pressure on the bladder neck, the urethra. I don't think that we hold to that one so much anymore. Or it may be just the contractility inside the bowel that is abnormal and sets up the constipation, and that may be abnormal in the same way that the detrusor contractility is abnormal. We don't know, but what we do know is if a child has daytime problems, it's quite likely they have some bowel dysfunction. Constipation is not one symptom, and this will be discussed by somebody else later in the program. There are a number of symptoms that have to occur, criteria that have to be met to say a child's constipated. Nonetheless, if you're treating someone with daytime wetting, you need to understand, is there any known reflux? What about urinary tract infections? And are you constipated? Again, would a child know they're constipated? Would the parent know if they were over 7 or 8? So this again is something you have to measure and document and quantify in something like a bowel diary. And this is our more recent study looking at overactivity in Australia here. And I don't think we get any more information. Just to point out that this one, constipation is more likely in symptomatic children. This is not a high level of evidence to say it's more likely, but it adds to the body of evidence that we have growing. And this is our big UK study. Again, telling us what we know, that you're going to see less of it in older children. And this point here, that you can have bladder control despite what's happening in your bowel. So I like to classify the disorders in a basic way, very similar to how we talked about the anatomy and physiology. I like to call them storage disorders and voiding disorders, to make it very clear in your mind. Now, there is a link between the two, and we haven't talked about that until recently, I dare say, and we're starting to understand, and I suspect that the voiding drives the storage disorders, whereas in adults, we think that it maybe is the other way around. So somewhere along the line, we have to come to some agreement. And here are the confounders that I talked about, the urinary tract infections and the reflux. So let's talk about these. We've talked a little bit about overactive bladder, so we're good with that. We know the symptoms, needing to void urgently, having to try and make some extra pressure to close down the lumen of the urethra and support the urethral closure mechanisms, and often going to the toilet to not pass very much because of these contractions that have occurred when the bladder is not full, the detrusor has contracted. And I've got some, I'll be able to show you this in a minute. And what are the signs? If we are going to measure the flow against the time, that's what we call a uroflow. And we can measure it on a special little machine. And we see that there's a lot of pressure at the start of the flow, and then it dies off. We call that a tower curve of the flow. There may or there may not be urine left in the bladder, post-void residual. It's not that common unless there's a dysfunctional voiding attached to it. Probably likely to see the child has frequent visits to the toilet, and they don't really pass the amount of urine you would expect for their age. in my opinion, any child with bladder dysfunction doesn't pass the amount of urine you would expect for their age. And there are equations that tell you, well, you know, exactly how many mils you should void for your age. Basically, you could take 200 mils as a rule of thumb for somebody who's sort of 7 and older. And we can also look at how the bladder is performing if we are able to fill up the bladder and monitor the pressures. Now, this is not something you can do in routine clinical practice, but if the child is investigated, you can get this information. Now, this is what we call a urodynamic trace. This is when we do one of these pressure storage flow investigations. This here says the pressure of the detrusor. This here says the pressure in the abdomen. And one of them should say the pressure in the bladder. Yes. So because we know there's all sorts of pressures inside the body, we have to know what they are first. That's what this abdomen line is, and it comes from a transducer that is in the rectum. And now this is a transducer that's in the bladder, telling us what's the pressures in the bladder. But because we want to take into account what's going on in the bowel, look here, this line here, something is causing increased pressure inside the rectum. We might not have this line and we just go, ooh, look at this in the bladder. But actually,